Hospital, Bangladesh. I would like to present case on assessing the quality of life of patients with percutaneous coronary intervention versus coronary artery bypass graft. Globally, cardiovascular disease, CVD, is the leading cause of death. One of the common CVD is coronary artery disease, CAD, which is caused by the accumulation of atheromatous plaque within the walls of the coronary arteries. To treat CAD, PCI or percutaneous coronary intervention and CABG or coronary artery bypass grafting are considered revascularization procedures. PCI is the medical intervention, whereas CABG is the surgical approach. However, there is no clear-cut indication of which procedure, PCI or CABG, would lead the better treatment outcome. Moreover, it is difficult to predict the treatment effects of PCI and CABG due to the volatility of cardiac blood supply and or ischemic detection. The quality of life is considered a significant concept and outcome in healthcare. To evaluate health-related quality of life, we can identify the physical or mental health status of the individuals and can improve their health. To assess the quality of life of cardiac patients, a 36-item short-form health survey, in brief it's called SF36, questionnaire is one of the most widely common health status instrument. The aim of the study was to increase understanding of the characteristic of illness and implication of health-related quality of life, to measure and compare post-PCI or CABG life. A retrospective observational study was done in 2019, conducted at 4 renowned cardiac hospitals in Bangladesh. Inclusion criteria was patient who had a history of PCI or CABG procedure at least 3 months or more prior to the study. And we have excluded the patients who developed post-operative complications or having comorbidity, were unable to respond to this study procedure. We took ethical approval from National Institute of Preventive and Social Medicine and all the 4 hospitals. Written informed consent was taken from all the participants. Questionnaire was done in native language. A face-to-face interview was conducted, and sample size was calculated, where it came 78 for PCI and for CABG group. Total it came 156, and data was analyzed by using SPSS. The health status was measured by medical outcome study SF36, which was used to measure physical and mental health status. This is a generic multi-dimensional tool, consists of 36 questionnaires on 8 health concepts. Responses to each item were scored and expressed as a score on a 0 to 100 scale for each of the 8 health concepts. A higher score indicates a better quality of life. Now I'll go in result. Table 1 shows the socio-demographic characteristics in PCI and CABG treated patients. Here you'll find that the age range from 40 to 92 years, 82% were male, and male participants were more in CABG than PCI. Also, majority were married. The occupation of the majority of participants in both groups were businessmen, followed by service persons. About 95% were Muslim. There is a significant association between religion and total quality of life. More than 50 studied of higher secondary education, followed by bachelor degree or above the bachelor. The table 2 shows health-related characteristics in PCI and CVG treated patients. Table 3 is the comparison between treatment groups according to scope of individual domains and quality of life. This table shows the average score of physical components and the average score of mental components, and also the total score for PCI and CVG respectively. This the figure shows the distribution of mean value of various domains of the physical component of quality of life. And the next figure shows the same of the mental component. So from the result, I can say that the mean plus minus SD of the total score of quality of life generated from all 8 domains were 78 plus minus 0.14 and 78 plus minus 10.92 for PCI and CVG respectively. The average score of physical component was 78 plus minus 12 for PCI and 77 plus minus 12 for CVG. And lastly, the average score of mental components was 80 plus minus 9 for PCI and 79 plus minus 3 for CVG. As the numerical values for quality of life between the PCI and CVG groups are commensurate with each other, the difference between PCI and CVG's total score quality of life and also physical and mental components were found non-significant. Health-related quality of life were higher among the PCI-treated patient in comparison to CVG-treated patient. Now the discussion. This study was conducted to compare the outcome of quality of life among patients undergoing PCI or CVG-treated procedures. Comparatively higher score of quality of life were found in the case of PCI component compared to CVG. Regarding the improvement of quality of life in both groups, most patients felt better after treatment, and only a few patients felt the same and worse than before the treatment procedure. Male patients had significantly more CVG compared to PCI. In contrast, female patients had significantly more PCI than CVG. Improvement of physical health was much slower for women after CVG surgery compared to male patients. The mean age was 59.49 years for PCI group and 58.1 year for CVG group. It indicates comparatively older group require or prefer CVG procedure. The average duration of suffering from diagnosis to treatment was 87 days for PCI and 122 days for CVG. And the difference was not significant. The treatment delay might have different factors. They need to arrange treatment cost. Sometimes they take a second opinion. The patient's mental and emotional factor also play a role. In contrast, most CVG patients felt significantly worse than PCI patient after treatment. We have some study limitations. Quality of life is a subjective measurement and assumes patients answer how they were feeling after PCI or CVG. So there might be recall bias. Patients with reintervention were not enrolled. So reintervention rate and influence of quality of life between groups were not determined. As a retrospective observational study, we could not compare pre and post-operative quality of life. In conclusion, I want to say that there was a significant difference between the principal treatment procedures of PCI and CABG, with participants' sex, religion, and health status compared to the pre-treatment state. The health-related quality of life was improved and felt better after receiving treatment in both PCI and CABG operated groups. This study's finding may help to assess further implementation of further health interventions for heart team physicians to make decisions for the treatment of revascularization. And last of all, I want to recommend further intervention studies with large sample size will guarantee a higher probability of determining factors that influence the quality of life. And that's all of my presentation.
Yeah, myself, Dr. Raja Ramesh, lead interventional cardiologist, Aster Ramesh Hospital, Vijayawada, India. So today in this prestigious meeting, I'm going to talk about the novel commissural alignment technique with the newer generation balloon expandable valve called Myval in TAVR. So this is the brief introduction about the topic. We all know that the transcatheter aortic valve indications were extending into low surgical groups. It is mandatory to achieve the commissural alignment for the lifetime management of the aortic stenosis. So why this commissural alignment? Because this commissural alignment facilitates future coronary axis, redo TAVR, and it also reduces the stress on the leaflets, thereby reduces the degeneration of the bioprocess. So as we all know, there are two different types of TAVR valves. One is self-expandable valve, other is balloon expandable valve. These commissural alignment techniques were well defined in case of self-expanding valves, but attempts with balloon expandable valves were disappointing. Secondly, these commissural alignment techniques were described for tricuspid aortic valves, but they are not suitable for bicuspid aortic valves, in which the coronary cups are asymmetric and coronary origins is not always from the center of the cusp. They will be eccentric origin. So in the present review, I'm going to describe a new novel coronary alignment or commissural alignment technique called Octacor technique by a balloon expandable valve from India called Myval by the Mary. So it is again, the TAVR indications are extending to the lower risk younger groups. So we have to plan the lifetime management of aortic stenosis at the index procedure itself. Why? Because unlike the surgical valve where the negative aortic leaflets are excised and bioprosthetic leaflets are exactly matched with the negative commissures, whereas in transcatheter valves, the alignment of the commissure is random. So we have to plan it and achieve the commissural alignment. So what are the factors in which the commissural alignment will depend? Because the coronary obstruction during the transcatheter heart valve depends. It depends upon the aortic root anatomy, like the height of the coronaries, width of the sinus, and width of the sinotubular junction, and the negative leaflets length. And the transcatheter heart valve features like frame height, internal skirt, and the relation of the transcatheter commissures to the negative commissures during the deployment. It is what is called attaining commissural alignment during the deployment. It is important to attain the commissural alignment, as told before, to retard the structural degeneration of the heart valve. And for the more advanced procedures like basilica, which we'll do for the valve-in-valve procedures, the attainment of commissural alignment is mandatory to facilitate these procedures like basilica. So the commissural alignment is not only important for coronary access, but also for the longevity of the transcatheter valve. It reduces the halt and harm, that is the hypoattenuated leaflet thickening and hypoattenuation affecting motion. So it is not only important for self-expandable valves, but also for the balloon expandable valves. So how the commissural alignment will be planned previously in the case of the self-expanding valves? It began on the CT analysis of the aortic root and the orientation of the delivery catheters of the self-expandable valves in a particular angle position at the femoral site, like the 3 o'clock position for the evolute platform, 12 o'clock position for the accurate near platform, and orienting certain markers like hat marker in case of the evolute and accurate near also the post of the valve frame towards the inner curvature or center back. In case of evolute, it is towards the outer curvature or central front. And in balloon expandable valves previously, crimping one of the commissures in a different clock position were tried, but it was failed. And one thing should be remembered that all these techniques are for tricuspid valve, but for bicuspid valve, due to the asymmetry of the sinuses, we have to target the coronary alignment rather than the commissural alignment. So I'm going to describe a newer technique called the Octacor technique with the use of a newer generation balloon expandable valve from India. It is called Myval by Mary. So the core concept of this Myval Octacor technique is we have to orient one of the commissures while crimping in the direction of the mid of the RCC in case of tricuspid valve, or mid of the RCA, that is right coronary artery, in case of a bicuspid valve, based on the CT derived images of the aortic root, which I'm going to show in the next few slides. So as there will be a 180 degrees of rotation of abdominal aorta to the aortic root in the thorax, the commissural post, which we initially crimped in the direction of the mid of RCC or mid of RCA, exactly falls opposite to them. That is in the commissure between the NCC and LCC during the valve deployment, thereby achieving the commissural alignment. So if you see here, if you carefully follow this yellow mark, this is at the femoral side, but as we are going from the descending aorta, thoracic aorta into the aortic root, see the yellow color is coming down. That means initially, whichever we have crimped in the direction of the right coronary artery here, it is falling exactly opposite to that of the right coronary artery in between the non-coronary and the left coronary commissure, thereby leaving the coronaries free. So this is what is called commissural alignment. So how to get this angle? So after attaining a axial cross section of the sinus of Valsalva from the aortic root, a central line is drawn passing through the center of the sinuses, and then perpendicular line to it, intersecting the first one. The intersection point is called geometric nodule, and the angle to the middle of the right coronary sinus or to the middle of the right coronary artery is called angle of commissural alignment. So if you overlap a clock on this one, you'll get an angle called the clock angle. So depending upon the origin of the right coronary artery or mid of the RCC, this angle can be acute, right angle, or obtuse. So this is what we are tackling. This is the three-dimensional clock angle. So this is called crocodile compass. So if you overlap this crocodile compass on our aortic root, so we'll get what is called clock angle. And depending upon where is the center of the right coronary sinus, this angle can be obtuse like here. It can be right angle like this here, or it can be acute like this here. So these are the different clock positions. So it has to be one of these three angles, the clock angle. So we have to deploy the transcatheter heart valve depending upon this clock angle. So how to confirm the commissural alignment once you obtain the clock angle and deploying the valve? How to know that we have attained the commissural alignment? So the commissural alignment can be confirmed either by fluoroscopy or by transesophageal echo or by post-procedure CT. The simple way is fluoroscopy because the patient is already on the table, so we can confirm. So it can be confirmed in two views called coplanar view and cusp overlap view. Roughly, the coplanar view is the elevocranial view and cusp overlap view is the arteriocardial view. In the coplanar view, if one of the commissural posts falls in the middle of the valve frame, and if the three commissural posts are equidistant from outer curvature to inner curvature, it indicates that we have attained the commissural alignment. So this is the outer curvature, this is the inner curvature. We can see at the middle of the valve frame. So this is the commissural post, and this is the other commissural post, and this is the other commissural post. So these commissures are equidistant from outer curvature to inner curvature, and one of the commissural posts has fallen exactly in between those two curvatures. That means we have achieved commissural alignment by the coplanar view. What about the cusp overlap view? This is the cusp overlap view. So if you see two of the commissural posts towards the outer curvature and one commissural post towards the inner curvature, it indicates there is a commissural alignment in the cusp overlap view. So these are the two views that we have to check after deployment to check for the commissural alignment. The other thing is demonstration by the CT. So take the post-procedure CT, and these are the negative commissures, and see where are the transcatheter heart valve commissures are falling. So if you are attaining the exact overlap with the negative commissures, that means your coronaries are free, you have attained the commissural alignment. So I will finish the discussion with a case example. So this is a 70 years male complaining of dyspnea with past history of coronary artery bypass grafting. So initially we thought of coronary artery disease, but coronary arteries are normal by the angio. Later an examination and the echo, we found the patient is having severe aortic stenosis with value area of 0.8 and P gradient of 118 and mean of 66. So we thought of we'll do TAVI for this patient, keeping in view he was a high surgical risk case with the past history of CABG. So we went ahead with the CT for the TAVI. So this is a three-dimensional aortic root analysis. It is a bicuspid type 1A valve, and it is severe aortic calcification, and the coronary heights on the left side is borderline 10.3. And so we thought of we'll do a balloon expandable valve with size of 27.5 mm valve with about around 7% oversize. So, and this is the aortic root. The area is the 550, and the average diameter is 27.3 annulus, and LVOT is slightly larger than the aortic annulus, and adequate signs of Valsalva, borderline left coronary height, and severely calcified. So in this patient, we thought of we will attain the commissural alignment. This is the axis site, reasonable axis site, like on the right side, it is femoral artery 9.9, external iliac 9.7, and common iliac 8.9. So we thought we will get our axis from the right side, the main axis. And we went ahead for the commissural alignment technique. So the clock angle for our patient is slightly acute angle 81 degrees. And if you overlap on the clock, we are getting a clock angle of 3/5. So we have crimped the valve in that direction. So this is how we get crimping. This is called crocodile compass. So this is our valve. This is the commissural post. So we have to clip in 3/5 position, and we have to crimp before taking into the patient. And this is the deployment. We have positioned the valve across the aortic valve, and this is the under rapid ventricular pacing. We have deployed the balloon expandable Myval, and this is the post deployment with a nice deployment with no aortic regurgitation, coronaries are flowing. And this is to confirm, and this is to confirm the coronary alignment. As I told, this is the coplanar view. And if you see one commissure falling exactly in middle of the valve frame from outer curvature to inner curvature, and if three commissural posts are equidistant, that indicates we have attained the commissural alignment. And this is the post-procedure CT that we have taken, and we can see the coronaries are free of the any commissures. This is the right coronary artery, and this is the left coronary artery, which is calcified, and we can see there is no commissural post here. So we have attained the commissural alignment by the octaling or correlating technique. So in conclusion, the commissural alignment in TAVR is important for coronary axis and for redo TAVR and for longevity of the index procedure, as it reduces the stress on the leaflets. The coronary alignment is not only important for self-expandable valves, but also for the balloon expandable valves. The current techniques described for the commissural alignment are not effective for bicuspid, as they are good for the tricuspid. In bicuspid valves, coronary alignment should be planned rather than commissural alignment, as the coronary origin is asymmetric. So the Myval Octacor technique by Octacor valve is novel one to achieve commissural alignment even in balloon expandable valves and even in bicuspid also. This technique has certain limitations in extreme tortuous aorta, as it affects the final position of the delivery system. And more number of cases should be done to validate this technique, and we are in that process. Thank you.
morning, everybody. I'm Dr. Lavanya. I'm a consultant interventional cardiologist at KIMS Hospital, Kondapur, Hyderabad, India. My topic today is colchicine and cardiovascular diseases. Just a second. This is not. So I will be talking about the introduction, pharmacodynamics, its role in pericarditis, both acute and recurrent, post-cardiac injury syndromes, the restless syndrome, coronary artery disease, atrial fibrillation, and wind up with a take-home message. So colchicine is an alkaloid extracted from the plant colchicum, also called the autumn crocus. Its therapeutic use for gout and familial Mediterranean fever is well known. Colchicine also plays a role in the management of CPPD, pericarditis, and Behçet syndrome. So we know that inflammation plays a major role in the pathogenesis of atherosclerosis and thus cardiovascular diseases. Colchicine, being an anti-inflammatory drug, is being widely studied and used in cardiovascular disease. Colchicine is readily available, has a favorable safety profile, and is cost-effective, hence making a resurrection in the recent times. So what is the mechanism of action of colchicine? It basically acts at the cellular level and blocks mitotic cells in the metaphase. It binds to tubulin to form a tubulin-colchicine complex, which in turn blocks the assembly and polymerization of microtubules. So colchicine basically inhibits the neutrophil chemotaxis, adhesion and activation, thus prevents the release of defensins, MMPs, and elastin, which in turn suppresses the NLRP3 inflammasomes and reduces the level of interleukin-1 beta, interleukin-18, and CRP levels, which in turn also reduces the proliferation of myofibroblasts and smooth muscle cells, so reduces fibrosis overall. So coming to the pharmacodynamics, colchicine is a substrate of both cytochrome P453A4 and P-glycoprotein 1 reflux transporter. The major side effects of colchicine are gastrointestinal, and that affects 10 to 20% of the population. The most common side effects are abdominal pain, diarrhea, nausea, and vomiting, followed by myalgias. The elimination is mainly by hepatobiliary system, and in those with normal renal function, 10 to 20% is excreted by the kidneys. So cytochrome P453A4 and PGP1 inhibitors, we know they affect colchicine mechanism. The strong inhibitors greatly reduce colchicine elimination, both the strong CYP3A4 and PGP inhibitors. So when the colchicine elimination is reduced, there is a chance of increased levels of colchicine in the bloodstream, and that can cause increased GI side effects. So these drugs and their interaction should be with colchicine should be kept in mind. So coming to acute pericarditis, we know that acute pericarditis is the acute inflammation of the pericardium. In 70 to 90% of the patient, it is often self-limiting without complications or recurrences. The diagnosis is often done by the following criteria, that is 2 out of 4 should be present, either pericarditic chest pain, pericardial rupture, new widespread ST segment elevation or PR depression on the ECG, and pericardial effusion, whether it's new or worsening. And the markers, it is associated with the markers of inflammation like the WBC count, C-reactive protein, and ESR. So once the diagnosis is made, the ESC recommends, this is the 2015 ESC guidelines on management of pericardial diseases. They recommend an ECG, a chest X-ray, and echocardiogram as a class 1 recommendation for diagnosis. And anti-inflammatory drugs are the mainstay of treatment, along with restriction of physical activity till the patient becomes asymptomatic. So the recommendations are that the aspirin or NSAIDs are recommended as first-line therapy for acute pericarditis with gastroprotection. You can see that colchicine has a class 1A recommendation as well for acute pericarditis as an adjunct to aspirin and NSAID therapy. So the commonly prescribed anti-inflammatory drugs are aspirin and ibuprofen, which are the class 1 drugs, which are usually used for 1 to 2 weeks, and then there's a tapering dose, whereas colchicine is used in a dose of 0.5 mg once a day for those who are less than 70 kgs, or it is twice a day dose for those who are more than 70 kgs. The duration is for 3 months. There is not necessarily a need for tapering, but if we do want to do it, we can take a dosage of 0.5 mg on alternate days in the last few weeks. Coming to recurrent pericarditis, recurrent pericarditis can be defined as new onset symptoms and signs of chest pain, frictional rupture, ECG changes, and elevated CRP. The diagnostic clinching point is the 4 to 6 weeks of symptom-free period. So if someone has an acute pericarditis, to diagnose it as a recurrent, there should be a 4 to 6 week symptom-free period. This can occur in about 15 to 30% of the patients. And the initial therapy is similar with NSAIDs and colchicine, but this combination needs to be continued until the resolution of symptoms and normalization of CRP levels, usually till 6 months and maybe even 12 months in difficult cases. If this combination fails, then triple therapy with the addition of steroids has to be started. So the therapies again include aspirin, ibuprofen, and indomethacin as the NSAIDs. And here you can see the treatment duration is from weeks to months. And colchicine again, 0.5 mg twice or 0.5 mg once, depending on the patient, weight of the patient, whether he's less or more than 70 kgs. And this should go for at least 6 months. We saw in acute pericarditis, the therapy was 3 months. Here we are going to treat the patient for at least 6 months. And tapering is again not necessary, but we can still do it as 0.5 mg on alternate days in the last few weeks. So the recommendations for recurrent pericarditis, like acute, aspirin and NSAIDs are the mainstay of treatment and are recommended at full doses if tolerated until complete symptom resolution, which is a class 1 level A evidence. And colchicine, like I said, is for 6 months, is recommended as an adjunct to aspirin and NSAIDs, which is again a class 1 level A recommendation. Colchicine therapy of longer duration, that is more than 6 months, should be considered in some cases according to clinical response. This again gets a class 2A level C recommendation. This is all again from the EAC 2015 guidelines. So what are the trials of colchicine and pericarditis? So they're different. There's a trial for acute pericarditis called the COPE trial, small number of patients, only 120, but then there was a definite improvement in those patients on the colchicine group compared to the control group, which was only on aspirin. In recurrent pericarditis, the 3 trials are CORE, CORD, and CORD2, which again had not a very large sizable number of patients. But again, colchicine showed definite benefit over conventional treatment, that is NSAID treatment, over the duration of follow. The main difference between the two, like I said again, is the 3-month treatment for acute pericarditis and 6 months for recurrent pericarditis. So the overview of both acute and recurrent pericarditis, colchicine plays a class 1A indication in both these conditions. Coming to post-cardiac injury syndromes. So post-cardiac injury syndromes, it's an umbrella term for a group of inflammatory pericardial syndromes. It includes post-myocardial infarction pericarditis, post-pericardiotomy syndrome, and post-traumatic pericarditis. So all these things are thought to be due to an autoimmune pathology, which is triggered by initial damage to pericardial and or pleural tissues caused by either myocardial necrosis, surgical trauma, accidental thoracic trauma, or iatrogenic trauma with or without bleeding. So the diagnostic criteria, 2 out of 5 should be fulfilled. That is pericarditic or pleuritic chest pain, fever without an alternative cause, pericardial or pleural rub, evidence of pericardial and or pleural effusion, and elevated CRP. At least 2 of these being fulfilled takes the diagnosis of PCIs. A special mention on Dressler syndrome, which is a pleuropericarditis which occurs after myocardial infarction. This is it usually occurs between 1 to 6 weeks following pericardial inflammation. It is a rare occurrence in the current era of early reperfusion and affects around 1 to 0.5% of the population. It is thought to be an immune-mediated reaction like all PCI syndromes following an injury to the mesothelial pericardial cells. So the recommendation for PCIs, the diagnosis is again high-grade fever, pleuritic chest pain, pericardial effusions, raised WBC count, and CRPs. And the management includes NSAIDs and colchicine in similar doses to that of pericarditis. So anti-inflammatory therapy is recommended as a first line, as a class 1 recommendation. Aspirin is again a class 1 recommendation, but here colchicine gets a class 2A recommendation. Colchicine, when added to aspirin or NSAIDs, should be considered for the therapy of PCIs as in acute pericarditis. And colchicine should be considered after cardiac surgery using weight-adjusted doses, that is 0.5 mg once a day for less than 70 kgs and 0.5 mg twice a day for more than 70 kgs. And without the loading dose for the prevention of PPS. So this is something new. For the prevention of post-pericardiotomy syndrome, also colchicine has been given a class 2A recommendation if there are no contraindications and it's tolerated well. And this preventive administration of colchicine is recommended for the duration of 1 month. Coming to the role of colchicine in coronary artery disease, like we already discussed, inflammation plays a major role in atherosclerotic pathway. And in atherosclerosis, inflamed endothelium attracts and activates neutrophil, which further activates platelets and leukocytes. So we already saw that colchicine reduces the neutrophil activation cascade and reduces the production of IL-6 and CRP. So what happened in the ACS scenario, colchicine has been shown in study basis to reduce myocardial reperfusion injury and also reduce the infarct size post-MI. But the Australian COP study, which included around 795 patients and where the patients were given 0.5 mg colchicine twice daily for 11 months, did not actually affect CV outcomes. In fact, it actually worsened those on colchicine. It was found to have a higher mortality rate, though it was not statistically significant. So the next trial which came out was the COLCOT trial, that is the Colchicine cardiovascular outcomes trial, again in acute MI. This included a large number of patients, that is 4,745 patients who had an acute MI within the last 30 days. So here the patients were on colchicine 0.5 mg once a day, and the follow-up period was for 23 months. So there was a significant reduction in the primary composite endpoint of CV death, resuscitated cardiac arrest, MI, stroke, or urgent hospitalization for angina requiring coronary revascularization by 23% in the colchicine arm, which is quite significant. Coming to stable coronary artery disease, we know that prophylactic long-term colchicine use was associated with low rate of CV events, mostly MI, which was seen in a retrospective analysis of gout patients. And this paved the way for the evaluation of colchicine in patients with stable CA. So there are two trials for that, the LODOCO and the LODOCO-2 trial, that is low-dose colchicine for secondary prevention of cardiovascular disease. Both the trials had the dosing of 0.5 mg colchicine, LODOCO with 532 patients and LODOCO-2 with 5,522 patients. So in both the trials, it was seen that colchicine reduced the primary composite of CV endpoint events, including CV death, MI, stroke, and ischemia-driven coronary revascularization. Coming to its role in PCI, PCI involves a local inflammatory response and endovascular injury. So post-PCI restenosis is largely driven by neointimal hyperplasia and arterial elastic recoil, which can be targeted by colchicine. So there were two trials here, the colchicine PCI and the coke PCI. The colchicine PCI had 400 patients, and the colchicine group found that inflammatory markers were significantly reduced. The coke PCI had a much lesser amount of patients, just 75 patients. Here there was significant reduction in periprocedural MI. So colchicine role in the revascularization and post-PCI has to be yet determined with more trials with large number of patients. Coming to its role in atrial fibrillation, we know that the elevation of inflammatory cytokines driven by NLRP3 inflammasomes promotes myocyte remodeling, fibrosis, and ectopic firing of the atria, leading to atrial fibrillation. Even cardioversion and radiofrequency ablation of AF is associated with high recurrences. The role of anti-inflammatory therapy with steroids, colchicine, and canakinumab in AF, although beneficial, has limited study data. So what is the role of colchicine in post-op AF? Post-op AF occurs in 16% of patients in post-cardiac surgery and 0.8% of patients undergoing non-cardiac surgery. This is associated with increased risk of embolic stroke, length of hospital stay, and higher healthcare costs. So colchicine now we know reduces the IL-6 and CRP levels. Both the COPS and the COPS-2 trials found that colchicine in the perioperative period reduced the incidence of AF by 35% during the follow-up period of 1 to 6 months. Even AF recurrence post-pulmonary vein isolation is associated with inflammation, and colchicine for prevention of early AF recurrence after PVI trial, though with a smaller number of patients, that's 161 patients, showed that colchicine 0.5 mg twice daily for 3 months was associated with decreased post-procedural AF recurrence at around both 3 months as well as 12 months. So my take-home message is that colchicine has already established its role in the management of pericarditis. Its role in other areas of CV inflammation, including post-cardiac injury syndromes, coronary artery disease, PCI, and AF is expanding. Colchicine, in addition to standard GDMT, should be considered according to the clinical situation. Due to its dose-dependent side effects, including GI events, infections, or pneumonia, lower doses can be used for long-term treatment. Colchicine is a relatively inexpensive drug and is available worldwide. And the anti-inflammatory properties and CV benefits of colchicine make it an attractive option for the addition in the CV therapeutic armamentarium.
Morning, everyone. So today now I am from basically a general surgery department, and so today now I'll be talking about a pilonidal sinus disease. That's like everybody knows the meaning of a pilonidal sinus. That means a cleft which is created with a tuft of hair, and maybe in between a gluteal cleft, in between intermembrane region, or maybe in between in umbilical region. Okay, so it is commonly seen in sacrococcygeal region, but rarely it occurs in periumbilical intermembrane region, referred to as extragluteal pilonidal sinus. Pilonidal disease, a cyst or infection, consists of hair containing sinus or abscess occurring in intergluteal cleft. It is speculated that the cleft creates a suction that draws the hair when patient sits or when patient does any workout. Okay, so next slide. So here I am presenting a case report of a 20-year-old male patient which presented to me with a 4-year history of intermittent and recurrent bloody discharge in the umbilical region. And there was a swelling also in the umbilicus, and the rest other medical history was unremarkable. On examination, it was observed that he had a hairy body. So wherever there is a pilonidal sinus disease, the most important what we observe in day-to-day practice is that patient has a hairy body. Okay, so he had a hemorrhagic discharge from inside the umbilicus, and there were unbound shafts of hair. Laboratory test, everything was normal. Ultrasound was within the normal limits. Yeah, next slide. So what the treatment we thought of performing was that a standard treatment of pilonidal sinus is to remove the complete sinus tract as well as any infectious material which is contained within the tracts. Okay, so we planned was to perform a sinus excision with umbilicus excision also, and umbilicus excision along with reconstruction of the umbilicus. Informed consent was taken from the patient, and under general anesthesia, a curved incision was performed along the inferior border of the umbilicus. The incision was deepened into the fascia along the full length of the incisions. The umbilicus was completely everted, and it was dissected, detached from the underlying fascia. The sinus which was present was completely removed. Now, to know the extent of the sinus, what we do here is that we inject dye. Maybe it can be gentian violet dye, indigo carmine dye, so that whole of the tract is delineated. And while once we know the tract, the passage of the tract, then it is very easy to perform the excision of the complete tract. Now, next slide. Yeah. So the defect which was created after excision of the tract, separate absorbable sutures was taken, and layer by layer, every layer of the skin was sutured back. The suture was removed on the 7th post-operative day. Histologically, specimen was sent, and it was compatible with the pilonidal sinus disease. Follow-up examinations were performed on the first, third, and the 6 months after the surgery, and there was no recurrence was observed within this period. Yeah, next slide. Yeah, so pilonidal sinus is a disease of recurrent chronic disorder that can be observed in the periumbilical region, and predisposing factors of these are hairy body, male sex, young age, and poor personal hygiene. Most common symptoms is itching, there will be a mass, there will be purulent discharge, there can be a bloody discharge also. Now, next slide. Yeah, so see, this is the preoperative image. The one on the left side, this is the preoperative image. We can see the sinus tract as well as the hairy body of the patient. Then this is the histopathological image. Yeah, next slide.
Everyone, I am going to present my prospective study on impact of clinical asthma phenotypes and myocardial performance and pulmonary hypertension in children with moderate to severe persistent asthma. So coming to the introduction part, asthma is a chronic airway inflammatory disorder, and chronic inflammation is not restricted only to lungs, but it affects the other organ system also. And the asthmatic children are at increased risk of developing pulmonary hypertension and right ventricular diastolic dysfunction. So if you see, this asthma and pulmonary hypertension looks two different entity, but the pathophysiological mechanism, they share the common mechanism of N-fat calcineurin pathway, and the mechanism of inflammation, smooth muscle contraction and remodeling. These are the common pathway, both of the disease entity they share. So based on this, we hypothesized this study that because of exaggerated respiratory effort in these children, there is increased intrathoracic pressure, and that lead to increased right ventricular afterload, and overall that leads to pressure overload of the right ventricle, leads to hypertrophy and dilatation of the RV, resulting in both systolic and diastolic dysfunction. So coming to the material and methods, this was the single center cross-sectional observational study, and it was time-bound study between July 2020 to December 21. And the 60 patients with moderate to severe persistent asthma, 30 were early onset vigor and 30 were late onset vigor based on Tuscan classification. That is, early onset vigor is if the asthma onset is within the 3 years of life, that is early onset wither, and after 3 years to 6 years of life, that is late onset wither. And the 60 age and sex match control were taken. The inclusion criteria were children and adolescent age group 6 to 8 years with moderate to severe persistent asthma and who can perform the spirometry. And the exclusion criteria were patient with a structural heart disease, patient with underlying chronic lung disease other than asthma, like restrictive and airway malformation. And if the children, they are unable to perform a spirometry, they were excluded from this study. This is the flowchart in which the 60 moderate to severe asthma were enrolled, 30 were early wheezer and 30 were late onset wheezer. Age and sex match control 60 were also taken. The demographic details, clinical examination and lab investigation were conducted. Chest X-ray and spirometry were conducted in all these patients. Restrictive lung condition and airway malformation were excluded. And asthmatic children were called for echo when their symptoms are well controlled. And similarly, the age and sex match control were also underwent echocardiography. And in this, we have studied basically the pulmonary hypertension and the RV dysfunction. And then finally, we did the analysis. So coming to the demographic profile of the cases and control group, we can see age. These are not only age and sex matched, but other parameters are also, there is no significant difference, a statistical difference between these parameters like height, body mass index, heart rate, systolic, diastolic BP, hemoglobin, platelet, and TLC count. So coming to the spirometry, we can see the FEV1 is significantly low in case group, in asthmatic group. And if we see the MPI, that is the myocardial performance index indicating of diastolic dysfunction, that is significantly higher in the cases. And the results are statistically significant. Similarly, TR gradient and TR velocity indicate the pulmonary hypertension that was also significantly higher in the cases group. The same result is shown in the box plot, MPI and PS systolic pressure for the cases and control group. Coming to the same result for the comparison between early onset wheezer and late onset wheezer, we can see there is the TR gradient is significantly higher in the early onset wheezer. That indicates the pulmonary hypertension risk are more in early onset wheezer, but myocardial performance index is more in the late onset wheezer. The same was a study with the correlation graph, and we can see there is negative correlation between the FEV1 FVC ratio with PA mean pressure and FEV1 FVC ratio with the myocardial performance index. And this was for all the asthmatic cases, whether early onset or late onset wheezer. Same we did the for early onset wheezer, and we can see there is significant negative correlation between FEV1 FVC with the PA mean and FEV1 FVC with the MPI. So the same result has been shown in the tabular form. And to conclude, incidence of pulmonary hypertension is about 33% in the asthmatic patient group. And we could find no studies on asthmatic children reporting the incidence of pulmonary hypertension. However, the incidence of RV dysfunction was 11% in our study. And this was far less as compared to 56% in a study conducted by the Reham et al. That was the Western data, not of Indian data. Similarly, MPI in the control was 0.38 versus cases 0.41. That was significantly higher. And that indicates the RV dysfunction is more in asthmatic patient. And this study was also, this similar study was also conducted by the Western group of authors, but there is no similar study in the Indian children for comparison. And so this study adds a unique feature of our research is evaluation of cardiac performance in asthmatic patient according to their clinical phenotype, early versus late wheezers. And the odd ratio for development of RV dysfunction was 3.2 in favor of early onset wheezer, whereas odd ratio for development of pulmonary hypertension was 0.74 in favor. That was again in favor of early onset wheezer. So conclusion, children with asthma in general and early onset wheezer in particular are at increased risk of developing pulmonary hypertension and RV dysfunction. So both pulmonary hypertension and RV dysfunction can easily be assessed by the conventional echocardiography as well as by pulse wave Doppler imaging. So annual screening with echocardiography is recommended in children with asthma.
So I am an obstetrician gynecologist, retired from Madras Medical College, Chennai. Okay. And he is Professor Dr. V. Seshaya. My respects to him. See, the prevalence of diabetes, it is increasing globally 453 million in 2019 has gone to 700 million in 2045, an increase of 51%. There are several reasons like aging population, nutrition, urbanization, lifestyle changes, and due importance not given to the GDM. This again depicts the same thing. It's a 54% increase. So pre-diabetic, when the diabetics are so much, we have pre-diabetics approximately 318 million, which is likely to increase to about 481 million by 2040. So diabetes has become an epidemic of unprecedented magnitude, words of Professor Andrew Bolton. And the hyperglycemia in pregnancy is defined as any degree of glucose intolerance with onset or first recognition during pregnancy. And GDM may play a crucial role in increasing the prevalence of diabetes and obesity. In 2019, the hyperglycemia in pregnancy in the age group of 20 to 49 years, that is 20.4 million or 15.8% of the live birth. In this, 83.6% were due to GDM. Hence, it is necessary to screen all pregnant women for GDM. The most economical and evidence-based test is a single test procedure called DIXI test. In the antenatal clinic, a pregnant woman has to be given a 75-gram oral glucose load, irrespective of whether she is fasting or non-fasting stage, and without regard to the time of the last meal. GDM is diagnosed if 2-hour post-glucose is equal to or more than 140 milligrams per 100 ml. This test can be done by estimating a plasma glucose from venous or capillary glucose by the plasma glucose calibrated glucometer. This procedure is being followed by DIPSI in India and is recommended by the Ministry of Health, Government of India, approved by WHO, FIGO, and IDF. So this GDM plays a crucial role in increasing the prevalence of, as I said earlier, diabetes, obesity, insulin resistance, increased atherogenic lipid profile, inflammatory markers, hypertension, endothelial dysfunction, and increased risk of cardiometabolic disorders. GDM is associated with even short-term maternal and fetal neonatal consequences for both mother and the offspring. In most instances, the glucose intolerance which occurs in the pregnancy reverts to normal, but substantial number of women with GDM, they have increased lifetime risk of developing diabetes over 3 times when compared to the control. By 17 years of age, 1/3 of children born to GDM mothers, they have had evidence of pre-diabetes, type 2 TM, metabolic syndrome, impaired insulin sensitivity and secretion, and the underlying pathogenic mechanism for the abnormal metabolic profile could be due to the epigenetic changes induced by the fetal exposure to hyperglycemia, that is the intrauterine milieu. So, the prevention of type 2 DM and associated cardiovascular complications should start during the intrauterine period and continue throughout life from early childhood. So, the preventive medicine should start before birth. In this aspect, GDM offers an important window of opportunity for the development, testing, and implementation of clinical strategies for prevention of diabetes and NCD. So, coming on to the prevention of diabetes, detection of diabetes does not mean prevention of diabetes. And what we need is a primordial prevention of diabetes, that is, the disease should not develop. Is it possible? If possible, to achieve the diabetes-free generation, for whom we have to focus. Les Kingley says female gender is the key for the diabetes prevention. How? The body's susceptibility to lifestyle diseases was programmed intrauterine. This is the famous words of David Barker. The intrauterine programming. So if you look at this embryology, the ovum is well supplied with the mitochondria, but the sperm contains few, and even those few do not persist in the offspring. At fertilization, it is only the nucleus of the spermatozoa that enters the ovum, and thus all the cytoplasm, mitochondria, and the mitochondrial DNA are exclusively maternally inherited. So an individual's phenotype is determined by the genetic, by the genetic potential of the individual, and also by the influence of the epigenetics, which is the intrauterine environment, and also the extrauterine environment, that is the postnatal environment. This popularly we call it as the genetic loads the gun and the epigenetic triggers it off. And epigenetic is more important than the genetic. So the diabetes mellitus, is it an intrauterine environment decided, or it is an inherited destiny, that is the genetic. And for this to demonstrate, we have the animal model where we start rats with a low genetic risk of diabetes when exposed to the hyperglycemia media of the goat rat in utero. It significantly increases the risk of the diabetes in adult life. And with the maternal glycemia and progeny, the offsprings of Pima Indians who were in utero when the mother had gestational diabetes mellitus have a greater risk of developing diabetes than their earlier siblings born before the mother developed GDM. So it makes it very clear that the intrauterine milieu is more important, and it is more than the inherited destiny. So hyperglycemia in pregnancy, the GDM, is the intrauterine milieu. So the women are, the gestational diabetes women are at increased risk of future diabetes, predominantly type 2 DM, as are their children. And also transgenerational transmission occurs. These are words of Don Hest Annie. So insulin resistance and increased atherogenic lipid profile, inflammatory markers, hypertension, endothelial dysfunction all lead to increases for cardiovascular disease. So GDM is the mother of non-communicable disease. These are words of Professor Seshaya, who is the father of GDM in India. So the diagnosis of GDM is possible by varied diagnostic criteria. There is a prediction at which the weak and glycemic level development of GDM occurs, we should know. And prevention is a measure to avoid the development of GDM and its consequences. So there are various criteria for diagnosis for the GDM like ADA, DIPSI, then PIGO, WHO, IADPSG, and NICE guidelines. And the different countries, they have different guidelines for diagnosis of gestational diabetes. And even the same country has two guidelines, which led to confusion among healthcare professionals. So we should not give importance to these all criteria. Therefore, the physiological glycemic level in normal pregnancy has to be recognized and implemented. That's a beautiful study by Hernandez, where he has studied the gestational age of 33 to 34 weeks, and the meta-analysis is done with 45 studies, where he has found the fasting blood sugar is 71 plus or minus 8 milligrams, and at 2 hours it is 99 plus or minus 10 milligrams, that is 110 milligrams. So any value above normal should be considered as abnormal. First time NIH study in 2018 suggested hemoglobin A1C of 5.3, that is 2 hour PP blood sugar more than 110 at 10th week predicts GDM. Hence, for prevention of blood glucose has to be, for prevention, the blood glucose has to be brought to less than 110 milligrams as the fetal beta cells start secreting insulin around 10th to 11th week. But so far, no study was done for the prediction as well as for the prevention of GDM. So if you look at this embryology and the histopathology, each islet cell of the beta cells, they function as an endocrine organ. In human pancreas begins to develop 4 weeks after conception, and first insulin deficit can be found between week 7 and 8. And pancreatic islets, they differentiate 10th and 11th week of gestation. They recognize and respond to the maternal glycemia at 11th week of gestation. So, making a concept that maternal 2-hour blood glucose should not cross more than 110 milligram at 10th week, as fetal beta cells start secreting insulin around the 11th week of pregnancy. So if you look at this example, suppose if the blood sugar around 10 weeks is 126 milligram, it comes to 12, by 12 weeks, comes to 112 milligram. It comes down without any intervention. How is it possible? That is because at 11th week, the fetal islet cells, they secrete insulin, and this brings down the maternal glucose, which is not desirable. So maternal blood glucose does not go up due to the fetal insulin handling of maternal glucose. At 12 weeks, the maternal glucose do not go up because of the fetal handling. When maternal glycemia starts increasing at the 11th week, fetal insulin starts secreting at the 11th week, which is irreversible. Once now there is hyperglycemia, more of fetal insulin is being secreted, and this trend is being kept up. It continues. So what is the gestational weeks? We have to look for this. So if at 10th week, PP blood sugar is more than 110 milligram, fetal beta cell insulin secretion starts and continues. And that is, we have to control the blood sugar and very early in pregnancy to prevent the establishment of fetal hyperinsulinemia. And screening for GDM is done normally routinely between 24 to 28 weeks. So presently, to test for glucose intolerance in the early weeks of pregnancy is recommended, which we call it as early gestational glucose intolerance or EGGI. So this is the PT handling of maternal glucose. When the mother's blood glucose level increases, it passes through the placenta to the fetus and results in that is hyperinsulinemia and results in adiposity. So the maternal hyperglycemia pushes the glucose and the fetal hyperinsulinism pulls the glucose. So that result, this is known as a fetal glucose steal, which happens across the placenta. Hence, maternal hyperglycemia and fetal hyperinsulinemia, they promote the fetal adiposity and results in the larger gestational age offspring. And this will result, if it is a male baby, in obesity, that is a childhood obesity, impaired glucose tolerance, and diabetes later on at an earlier age. And if it happens in the female, there is a childhood obesity and GDM during pregnancy and diabetes later on in an earlier age. So the prediction of GDM is 2-hour PP blood sugar more than 110 milligram at 10th week. Hence, at 8th week itself, 2-hour PP blood sugar has to be estimated. If it is less than 110 milligram, follow up by monitoring the CPT at the 10th week. If it is more than 110 milligram and less than 119 milligram at 8th week, a grace period of 2 weeks is available to attain the 2-hour PP blood sugar less than 110 milligram at 10th week with MNT and metformin. These are the references, and this leads on to. So if 8th week, if it is more than 110, you intervene with the medical nutrition therapy and metformin. And 10th week, it becomes less than 110. The grace period of 2 weeks is there for you to bring down the blood sugar to less than 110 milligram. So at 11th week also, it is less than 110 milligram. So there will not be hyperinsulinemia. So there is no increase in fetal beta cell insulin secretion. And following week, it is maintained at 110. So if it is more than 110, the fetal beta cell secretion starts increasing and results in problem. So this shows you the embryogenesis. Most of the organs are formed before 8 weeks of pregnancy. So if you look at the fetus, before 8 weeks, the organogenesis. Around 8 weeks, the organogenesis is over. So the PP blood sugar throughout pregnancy has to be maintained between 99 plus or minus 10 milligrams. And if necessary, we can start on metformin, which is safe as the embryonic stage is over by the 8th week. And metformin is safe for use throughout pregnancy. The glucophage, these are the references. Glucophage metformin was approved as the first oral anti-diabetic medication to be used safely from conception to birth. It's in the European guidelines, NICE guidelines, and Lancet everywhere says metformin is safe for pregnancy. So initiation of metformin, but remember, initiation of metformin after the 12th week, that is when the fetal hyperinsulinism has already occurred, it will not be effective in preventing the GDM. So this is our paper which was published in Curious, where the initial stages when we formed the concept of using metformin and MNT when the blood sugar level is more than 110 milligrams. So this concept has become a reality, and I'm presenting the outcome of a preliminary study which we have done, and the project has been sponsored by USV. See, we have grouped the patient into group A and group B. Group B, group A is the 8th week 2-hour PP blood sugar less than 110 milligram, and group B is at 8 weeks 2-hour PP blood sugar more than 110 milligram, and intervention is with metformin and lifestyle modification was given to them. So the first group, the A is 82 cases, group B is 69 cases, and if you look at this tabular column, the 82 patients in the group A who had a blood sugar, 2-hour blood sugar less than 110 milligrams, only one patient in 3rd trimester developed a GDM, and she is the gravida 6. Okay, and in the group B, out of 69 patients, again one patient developed GDM in 3rd trimester, and when we went to this, the details of her, she has stopped the metformin at 24 weeks. This is the graph to show you the glycemic level from 8, 9, 10, 11 weeks. That is the lower one, that is no intervention group. So you can see a straight horizontal line. So throughout that 4 weeks, the blood sugar is being maintained. And the 110 above patients were started on metformin. You can see the line coming down. This is up to 11th week. And these patients were tested for GDM by the BIPSI test. So the lower one is the no intervention group, and the upper one is the intervention group. See, the intervention group is effective. The intervention is effective in bringing down the blood glucose level, and they meet at the 32 weeks. So these are the basic characters of this subject we have studied. In this, the age alone is statistically significant. Other factors like, previous fetal wastage, the gravidity, type of delivery, term of delivery, family history, BMI, they are not statistically significant. This is the secondary outcome, the primary outcome, where the blood sugar levels of the 11th week, 8th week, they are all compared. Up to 11th week, they are statistically significant. And when the OGCT is done, from 16, 24, and 32 weeks, it is not statistically significant. And the secondary outcome, birth weight, cesarean section, all these things not statistically significant. So the results in this study, there were 69 women have PP blood sugar more than 110 who participated in the intervention group, and 82 women PP blood sugar less than 110. And it is observed that the mean age between the groups is statistically significant. The proportions across the gestational week in the two groups are not statistically significant. The other basic characters such as gravity, as I told you, they are not statistically significant. They are similar in both the groups. And the table 2 shows the primary and secondary outcome of the study. As regards to the primary outcome, the mean PP blood sugar value less than 0.05. And a gradual decrease in the mean PP blood sugar observed in the intervention group, and almost similar PP blood sugar noticed in the later weeks of 16, 24, and 32. The difference in the mean value of the OGCT is not significant between the two groups. The mean OGCT value is emerging at 32 weeks by both the groups, and it indicates that the intervention has significant impact in controlling the glycemic level as good as normal patients' glycemic level. Though the glycemic level of the interventional group is little high, but it is not amounting to GDM. The secondary outcome, the birth rate of babies in the two groups is not statistically significant. The mean birth rate of babies in the two groups are similar. In the intervention group, the indication for cesarean is 30.4%, and the percentage of neonatal complications is observed in the study. It is found that presence of complications is 65.2%, and it is statistically significant. In the secondary outcome, the maternal morbidity is also observed in both the groups. Maternal morbidity in the interventional group is 18.8%, and the statistical significance is there. So we have categorized the abnormal glucose tolerance during pregnancy as GDM when the PP blood sugar is more than 140 milligrams, where they are prone for future type 2 diabetes. And it is the second category is gestational glucose intolerance, where the 2-hour PP blood sugar, that is post-glucose, 2-hour post-glucose blood sugar is between 120 to 140 milligrams. And they are associated with adverse pregnancy outcome, a paper we have already published, and they are prone for future type 2 DM also. And third is the early gestational glucose intolerance called EGGI, which is detected at 10th week. It is PP blood sugar based. The GDM and GGI are post-glucose based. That is where we give a glucose and do the test. This is postprandial blood glucose related, where the 2-hour PP blood sugar should be around 110 milligrams. Still, they are prone to, if it is more than that, they are prone to develop GDM and diabetes in the female, and IGT and diabetes in the male. So normal glycemia in pregnancy is where, according to this, according to the glycemic graph I have showed you, is so our PP blood sugar should be 99 plus or minus 10 milligram % throughout pregnancy. So prediction of GDM is 2-hour PP blood sugar more than 110 milligram at 10th week, and preventive action has to be taken at the 8th week so that the maternal blood glucose remains less than 110 milligram throughout pregnancy, and metformin and MNT to continue until confinement. Follow-up is essential after delivery. So the throughout pregnancy, the 2-hour PP blood glucose has to be maintained between 99 plus or minus 10 milligrams. From conception to confinement, the 2-hour PP blood sugar should be between 99 to 109 milligram %, and monitoring 2-hour PP blood sugar at 8th week, 10th week, 12th week, 16, 24, and 30 seconds. If you want, you can do the GDM testing and rule out GDM. So 8th and 10th week, not necessary, as metformin won't be used. That is, sorry, after 12th week, the metformin is not necessary because it will not be useful. So this I told you earlier. So the antenatal women should be checked between 8 weeks and 10 weeks and look for the PP blood sugar less than 110 milligrams. So the womb is more important than the home, the words of David Barker. So it all starts in the utero. Hence, for diabetes-free generation, we have to focus on the features for the future. Again, our Father Seshia's words. So the blood test at appropriate time and follow-up prevents the transgenerational transmission of diabetes. And we can use acute check glucometer Already we have published a paper on this. Hence, let us all pledge for the primordial prevention of diabetes. And this is the logo we want to have for primordial prevention of diabetes. With this, I thank you very much for the opportunity given to me. Thank you once again.
Gentlemen, I want to propose our report, interesting experience in diagnosis and surgical treatment of rare heart tumors. Next slide, please. Next slide, please. The aim of the study is to present unusual case of diagnosis and treatment of rare heart tumors. Next slide, please. The detection rate of primary heart tumors in cardiac surgery clinics range from 0.09 to 1.9% of total number of hospitalized patients. Cardiac myxomas account for up to 75% of heart tumors. Next slide, please. On this slide, we can see quantity and structure of primary heart tumors in Amosov National Institute Cardiovascular Surgery from 1969 to 2024. 1,033 interventions were performed in heart tumors, which heart myxoma was severe localization in left atrium, 87.9%, in the right or left ventricle, 0.9% subsequently, and multiple localization was in 1.3%. Next slide, please. On this slide, we can see multiple and gigantic myxomas of left atrium, and with fibrosis and calcinosis, this gigantic myxomas and damage for the mitral valve. Next slide, please. On this slide, we can see structure of non-myxomas benign tumors, primary tumors. There were fibroma, rhabdomyoma, lipoma, hemangioma, and leiomyofibroma. And most of all, there were papillary fibrillostoma, and 35% of quantity of benign primary heart tumors. Next slide, please. On this slide, we can see tricuspid valve leiomyofibroma, echocardiography investigation. There were congenital pathology with damage of anterior leaflet of tricuspid valve, discovered accidentally during the prophylactic examination, and the clinical pictures was rhythm disorder in form of group ecstasies. Next slide, please. On this slide, we can see micropreparation of tricuspid valve under leiomyofibroma. We can see there were anterior leaflet of tricuspid valve with this pathology. Next slide, please. On this slide, we can see mitral valve hemangioma. In this case, differential diagnosis with cardiac echinococcus was required. We can see hemangioma on echocardiography examination and in the operation. Next slide, please. In this slide, we can see macro preparation of mitral valve hemangioma, size 5 on 3 on 2.5 centimeters. the papillary muscle from which the neoplasm originated is visible. Next slide, please. On this slide, we can see lipoma of the right and left ventricle in 2 cases from 3 patients with lipoma of the heart due to transmural growth required heart transplantations. And on this slide, we can see heart after the removal of this lipoma of left ventricle. Next slide, please. On this slide, we can see valvular lesions in non-myxomous heart tumors. There were papillary fibrillostoma on mitral cusp of mitral valve and gigantic papillary fibrillostoma near the 5 centimeter in diameter. Next slide, please. This slide we can see structure of malignant heart tumors. Most of all, there were angiosarcoma, 35.7%, and other type of sarcoma. There were rhabdomyia, leiomyia, fibrochondral liposarcomas, and malignant fibrosis histiocytoma, malignant myxoma, lymphoma, and mesothelioma. Next slide, please. On this slide, we can see a very rare case of Burkitt of tumor, the Burkitt's lymphoma. 25 cases in literature, most often in the South America and West Africa. There was a patient, male, 27-year-old, hospitalized with diagnosis myxoma right atrium, and post-examination diagnosis was a tumor of right atrium and right ventricle and left ventricle, part of tumor covered tricuspid valve. During the operation, there were part of the tumor in the right atrium was removed, and blood flow obstruction, tricuspid valve competent. In the post-operation period, courses of chemotherapy and hormonal therapy. In 3 years, the complete disappearance of tumor tissue. On the echocardiography examination, you can see after 3 years after operation. Next slide, please. This slide, we can see micropreparation of right atrium fibrosarcoma. There was metastasis of fibrosarcoma of left scapula. Patient male, 49-year-old, the operation revealed dense fusion of tumor with the wall of the superior vena cava and anonyma vena. Next slide, please. On this slide, we can see removal of the left atrium angiosarcoma. Patient male, 24-year-old, the operation involved plastic surgery of the posterior wall of the left atrium and the posterior cusp of mitral valve. You can see very big angiosarcoma. Next slide, please. On this slide, we can see metastasis of seminoma in right ventricle, micropreparation of seminoma. Patient male, 24-year-old, the operation removal of tumor metastasis from the right ventricle and tricuspid valve repair. Second operation, after 1 month, there was removal of seminoma. You can see seminoma. Next slide, please. On this slide, we can see immature teratoma of mitral valve. Patient male, 21-year-old. A cluster-shaped tumor was attached to the heart of anterior leaf of mitral valve with small mitral insufficiency, which disappeared after the resection of the concerned heart of the mitral valve. The first manifestation of disease was acute coronary syndrome, for which the patient underwent stenting of the anterior descending branch of left coronary artery. You can see part of the tumor in descending left coronary artery. Next slide, please. Summary. First, among the tumor of the heart, there are often very original ones that require increased attention to diagnosis. Second, diagnosis of heart tumors depends on visualization during surgery and subsequent histological examination. Third, the tactic of surgical treatment of heart tumor are often decided during the operation. Therefore, each operation for this pathology is individual. Thank you for attention.
So, Bismillahirrahmanirrahim. Next slide, please. So today's I would like to see my paper, one of my paper, the role of coronavirus disease 2019 COVID-19 virus pandemic in the upgrading of personal hygiene. It is a cross-sectional study which is done in Saudi Arabia, and I would like to thanks to all the organizers of the scientific conference to giving me the opportunity to present my paper with you. And next slide, please. So as we know that the main reason for worldwide diseases are the viruses. We have a lot of disease by bacteria and the parasites and all, but we have seen that the virus disease which are caused by the viruses, they are the most, you can say, the dangerous one and the lethal one, which cause so many deaths, and their effects are very hazardous and detrimental effects on our body. And due to their resistance with the antibiotics, antiviral, and the other medicines, it is very difficult to deal with them. And if someone is immunodepressant and they have some cancers and they have some source of deficiencies, then the disease consequences will be very lethal. And it is very contagious phenomena. Whenever someone has a viral problem or viral disease, it will be contagious and it will be transferred from viral droplets and all the other means to the other person very quickly. So that's why we have to care about it, and we have to take all the precautions not to spread one by one from individual to another individual. And so we have COVID-19, and this is the infectious disease which is caused by COVID-19 viruses. Its genetic material may be DNA and RNA, and the thing is that all the world was very much difficult situation, because we know that they have very, very hazardous effects. Their hazards will be on their economy, on their health. We were in the very difficult situation. Next slide, please. So the sudden outbreak of this virus, coronavirus, it is discovered by the Wuhan and China, and it is caused by the SARS-CoV virus. In just 2 months, it is spread by worldwide so much. Steadily it is spreading, very rapidly spreading to the rest of the world, and we have seen that it was becomes pandemic, and WHO discovered that it's a pandemic issue. And this is the coronavirus. It is caused by the RNA viruses belonging to the family of Coronaviridae genus beta coronavirus 11. And the first coronavirus which was discovered before is RNA viruses, which is belong to this group. It is a beta coronavirus triggered by the coronavirus in the worldwide. So the next slide. So we have many effects by these viruses. And the thing is that this spread by many countries, and the poor countries, which are the developing one like Pakistan, India, Bangladesh, they are affected much more because they don't have the precautions and the healthy measurements to prevent their spread. So we have seen that it is spreading. It's caused so many deaths, and then the WHO has give us some guidelines to prevent their spreadings, and also they try to be to make some vaccines and all. They give some antiviral agents, which are at that time was so much frequently used. And we try to prevent all the things, and we have done all the preventive measures. There will be the social distancing, there will be the use of masks, there will be the other measurements which were performed by all the individuals worldwide. Like we have to take care about the social gatherings. So this is the particular structure of the coronavirus. We have seen that it has a SARS-CoV-2 genome inside, and then it has very small spikes on which is made up of glycoproteins, and they have a membrane. They have a nucleocapsid proteins of RNA, and they have an envelope proteins. So this is the typical structure of the virus. So we will try to make some vaccines, and now some of the little bit, you can say we are successful in making vaccines for that, and we have a somewhat role of some medicines. So we have done with the things like this, the preventions, the medicines, and the vaccines. So we have done at that time when it was a pandemic, we have done a study which is based on the interviews, and we have taken their consent, and then we try to ask some questions, and we have asked before and after, before the coronavirus, how much they are doing that activity, and when they are suffering from these infections, what the things and what the changes in these measurements which be done. So this method of study was, can you please change the slide? Next one. I have done with this. Yes, next one. Yes, next. Next. Yes, I am on objectives of the study and the methods of the study. So the methodology, can you please, next slide, which is done on the methodology? Yes. So the method was that we have an administer a questionnaire, and we determine all the alterations in the personal hygiene practice due to the pandemic, which is compared with the pre-pandemic measurement, and the phase which is before the this pandemic. Next one. So we have seen that before the pandemic, there are some major peoples, they are doing some activities, they have many more social gatherings, they have many things, and these all the individuals, they have doing some activities like before taking any food, before taking any coming in the house, whether they are having some measurements like they are washing their hands before meeting with someone, either they are having some use of some face mask and wash their hands. So we done all these measurements before eating, before doing any activities, and we have some positive findings that overall all the measurements, the activity in the personal hygiene, they are increased other individuals, and they are also including the female and the male, and the ages is between the greater than 20 to less than 60s. And they are all, this is the educational patients, individuals, and they're also, we have noticed their social and the marital status. And also we have asked the questions about their, that what are the team, how they know about the COVID-19. Yes, next, please. So everyone can see our results. The next one. Can you please make the next one? Yes. Yes. So we have this socio-demographic data, which we already, I have already described you. So we will go to the next slide. Next one, please. Yes. This is the diagrammatic picture. And the first one is telling you about the how much they have covering their mouth and nose by the face mask. And also when they are coughing and sneezing, they will cover their nose and face. So we have seen that before and after and during the pandemic, overall ratio is increased. And when on the guidelines, they ask them to follow it, and the ratio is increased. So during this phase, before eating and after eating, again we have seen the similar results, that overall all the individuals, they strictly follow the rules and strictly follow the personal hygiene things, that they have to wash their hands because they are coming from the outside. Maybe they are infected, maybe they will meet some other ones. So they are not involved in washing hands practice before the pandemic as much as compared to the during the pandemic phase. They are strictly washing their hands. They are strictly doing all these things, all these measurements during the phase, because they would not like to transfer this infection to their children and the other ones. Also, we have measured the hand sanitizer use, and we have seen that the sanitizer use is increased. And also we have seen that how much they are having a handshake practice, because we have asked them not to shake the hands, because we don't know whether the individual is carrier or whether the individual is infected or not. So we have seen that overall the handshaking, they also it's affected on that this practice also. They are trying to just say good evening and good afternoon, and then they have to reduce the handshaking and meetings and greetings by touching and all. Okay, so next slide, please. So now we have asked about some of the questions, that how frequently you are washing your hands. And the next question is how regularly you are cutting your nails, and the other methods like what are the things which you are covering by your face, your mouth? Did you cover before and after? So we have seen that overall these practices increased during the pandemic. Next one. So we have seen that before the COVID-19, the mean is 23.32, and then after it was almost increased by 18. So the overall the duration of the washing hand, because we have a specific duration to hand wash. We have to wash it by all means, by thumb, between the fingers, between the web area. So there is a particular method which is we have given some videos and all, and WHO help us for these guidelines also, how to they wash their hands so that every part of the hand will be free from any viruses. So we asked the duration, and also how they will frequently they wash their hands. So this frequency is increased, the duration is also increased. This is a positive point that they are very careful about this practice, and they are doing this very well. Okay, next one. So we have many of the things we have seen that the detection of this viruses is by nanoparticles, and we have another measures also. And we have antiviral activity, which can be shown by these particles. So we have much more studies done on this viruses, how we can prevent, what are the preventive measures, what are the vaccines available, and which one drug is the most effective. So nowadays there are much more studies has been done for all these measurements, antiviral drugs, anti-vaccines, their preventions and all. Next one. So we have a conclusion by our study that overall the personal hygiene practice is increased, and all the individuals who are suffering in this situation, they have tried to make them very much careful by doing all these practice in a very well way. And they are using all these preventive measures consciously, unconsciously. They are trying to keep the social distancing. They wash their hand very frequently. They are trying to make all the measurements which are given in the guidelines by various authorities. And we have seen that this is the main reason. The precautions are the main powerful tool for the prevention of any viral disease, to be just with the other things. Okay, next one. So, yes, this is all we have seen that the conclusion is that we have to do this practice. We should have to continue with this practice, because this is not only the coronavirus, the other viruses also, they have the same, mostly they all are contagious, mostly they all are transmitted by the viral, or you can say respiratory droplets. They are all infected by hand to hand or touching and all the things. If we have infected hands are carry these viruses, then we can transfer it by various means like shaking hands, by all. So overall, the preventive tool, the prevention, and you can say that the personal hygiene is the most effective tool for the prevention of all the virus and disease, including the coronavirus disease. Next one. Yes, this is the same thing, that the importance of the practice, and during the any viral disease, we have to protect it by our personal hygiene practice. So these the next slide, please. So these all are the references which we have used to carry out these studies. Next one. And with this, I would like to thank.
Good afternoon, everyone. Myself, Dr. Shobhit Mathur. I'm from India, and I'm basically a cardiac surgeon. I'm working at UN Mehta Institute of Cardiology and Research Center, which is a 1,100-bedded, largest super specialty, single specialty hospital in Asia. So, being a high-volume cardiac center, we did a study on tricuspid valve, in which I was the corresponding author, and it was an original article published. And thanks to Science Conferences for selecting that article for this webinar session. So I'm going to present that article today. The title stands as Tricuspid Valve Replacement Outcomes in a Diverse Variety of Valve Replacement Cases. This means, okay, tricuspid valve replacement is a known procedure. But in the study, we have included tricuspid valve replacement along with other valve intervention cases that were done in a single patient. For example, mitral valve replacement along with tricuspid, aortic valve replacement along with tricuspid, or triple valve replacement, mitral, aortic, and tricuspid. So we did a study on those cases, and the outcomes were basically mortality, the outcomes were regarding mortality and the choice of valve, mechanical versus biological. And it is a single center study, an original article published. So let's start now. So coming to the introduction part, next slide, please. See, whenever I say TVR, the capital R means replacement and the smaller r means repair. So it's a debatable thing that whether tricuspid valve replacement is better or tricuspid valve repair is better. Tricuspid valve replacement is still considered inferior for tricuspid valve intervention. The reason being, in severe right ventricular dysfunction cases, in severe TR cases, high chances of CHF, that is congestive heart failure. Replacement can lead to early mortality as compared to repair, high chances of renal failure, increased hospital stay, and worse survival ratio. See, all these things that I've mentioned here, they make tricuspid valve replacement as an inferior option as compared to tricuspid valve repair. And these are not my words. There has been a study, published study done by the likes of Pava S and Saran N, published in the European Journal of Cardiothoracic Surgery. See, whenever I'll be using some references, I'll be quoting those references. So they have been quoted here. So they did a study and they have given this data to us. Next slide, please. Okay, so mechanical versus biological processes. Any valve replacement, the two types of processes available today are either mechanical processes or tissue valves or the biological processes. So again, this is a debatable thing for tricuspid valve, that whether mechanical processes are better or the biological processes are better. Recent meta-analysis done by the likes of Najim S, Arafat A, as mentioned in bold in red in the last line. They published a systemic review and meta-analysis, and the outcome was that equal risk of 30 days and late mortality. Equal risk of 30 days, that is early mortality as well as late mortality. Equal risk is same with both types of valves. Also, the rate of reoperation and 5-year valve failure is same for both the valves. So up till here, looking at the literature, we conclude that mechanical versus biological processes both stand an equal chance of complications, and tricuspid valve replacement is a bit inferior to tricuspid valve repair. So our study basically included next slide, please. So our study basically included tricuspid valve replacement cases. At our institute, that is UNMath Institute of Cardiology and Research Center in Ahmedabad, we have taken cases that were operated at our institute for tricuspid valve replacement from 2017 onwards. And this is basically a retrospective analysis done through medical records. I mean, the cases were operated, they are coming to us in OPD follow-up, or we have the records. If a mortality has happened, we have those records. So it was totally a retrospective analysis done through medical records. Mortality and mechanical versus biological valve complications were taken into account to study the outcome of our study. Next slide, please. Now coming to materials and methods, a total of, tricuspid valve replacement is not as commonly done as mitral and aortic valve replacement. So a total of 42 tricuspid valve replacement cases were included in the study. 31 cases had bioprosthetic valves implanted and 11 cases had mechanical valves implanted. That means 73.8% cases had bioprosthetic valves and around 26% cases had mechanical valve implanted. Mean age of patients included in the study was 36.3 years, and retrospective study done through medical records, data collected from OPD follow-up, and also telephonic follow-up was taken. Cases with TV repair were not included. Tricuspid valve, the commonest surgery is tricuspid repair. So those cases were not included, and 42 selected cases for replacement were included. So as per the cases included, we can see that 35.7% cases underwent isolated tricuspid valve replacement, while 38% cases underwent tricuspid valve as well as mitral valve replacement. Okay, so isolated TVR, 35% cases were included in the study, and TVR with MVR, 38% cases. 2 cases of TVR were done combined with aortic valve replacement. That is, in one patient, That is, in both the patients, TVR as well as AVR was done. While triple valve replacement, that is tricuspid valve with mitral and with aortic, all three valves were replaced in 8 cases. 1 cases we had tricuspid valve replacement done along with pulmonary valve replacement. So we can see that the cases that have been selected for this study, as per the title of our study, are a diverse variety of valve replacement cases. Okay, so among the isolated tricuspid valve replacement cases, concomitant procedures that were done were pacemaker implantation in one, pulmonary endarterectomy was done in 1 patient, beating heart bidirectional Glenn shunt was done in 1 patient, and RM exomaxogen was done in 1 patient. Both the cases in which TVR was combined with aortic valve replacement had rupture of the sinus of Valsalva that was repaired. So the gist of this slide is that basically tricuspid valve replacement along with other valve replacement cases were included in the study. Initial trial of repair. Next slide, please. Initial trial of repair was, as tricuspid valve replacement is the established norm and a preferred norm for tricuspid valve interventions. So initial trial of repair was tried in 33.3% cases before making a decision for replacement. Now, the decision whether to put a biological or a mechanical valve was totally based on age of the patient. Younger patients were prioritized for mechanical valves. Obviously, they have a longer life left, so we need to avoid redo surgeries due to degeneration of biological valves. Biological processes were utilized in isolated TVR cases regardless of age. Those cases that had only TVR done, biological processes was used regardless of age. Leaflets of tricuspid valve were not excised in 5 cases, with isolated TR as the only lesion. So if the lesion was isolated TR, we preferred to retain the leaflets. Leaflets were excised basically in the cases in which previous interventions have been done, previous surgery, replaced valves, severe stenosis, fusion of leaflets. Bioprocesses, the sizes that were used have been mentioned, and how many cases that have been mentioned. And mechanical processes, what sizes were used and how many cases that has been mentioned. For post-op anticoagulation, we preferred warfarin, 6 months for bioprosthetic valve, for bio valve, and for whole life for mechanical valve. And target INR range was 2.5 to 3.5. So all these data have been summarized in this table. Next slide, please. Can you go to the next slide? You can see I mentioned the mean age of the patient. 28 patients out of 42 were female. That means 2/3 patients were female. Midline sternotomy was the standard approach used in 41 cases. Only 1 mini surgery was done. Associated procedure, MVR was done in 16 cases, 30% I've already spoken about. So basically all this, the data has been summarized in this table. The redo surgery, out of all the surgeries, 13 cases were redo surgeries. What were the findings? Whether the valves were stenosed, regurgitant, mixed, how many cases along with their percentages have been mentioned. Trial of repair was tried in 14 cases. Valve use, biological valve in 31 out of 42, and mechanical valve in 11 out of 42. Okay, next slide, please. Next slide, please. So coming to the results of the study. First result that we calculated was early mortality. That means within 30 days. Early mortality was noted in 8 cases out of 42. That means 19% of the cases. Out of these 8 cases, 2 cases had on-table mortality, while other 6 died in ICU in the first 30 days. On-table cases, obviously, they could not be weaned off due to severe right ventricular failure and uncontrolled hemorrhage, and both were redo cases. The cause of death that has been evaluated in all the early mortality cases, and I mentioned in bold and italics, is right ventricular failure in all cases. This was the common factor and the common cause in all the cases. All 8 deaths were right ventricular failure was the common cause. Second commonest cause was multi-organ failure in 7 cases out of 8. The mortality that happened in isolated cases of tricuspid valve surgery, 3 out of 15 cases, were due to advanced situations, high NYHA class, ascites, liver dysfunction, previous cardiac surgery, that is, redo surgeries. No early mortality, luckily, and no early mortality was noted when tricuspid valve replacement was done with aortic valve replacement and pulmonary valve replacement. 1 patient in the early 30-day period developed CHP, and permanent pacemaker was intra-op operatively placed, and the patient was subsequently discharged. Now coming to the other outcome that we calculated, that is late mortality. Late mortality happened in 11 out of 42 cases. Now, these 11 cases are exclusive of those 8 early mortality cases that we have discussed. That means 26.2% cases, we had late mortality. And in our study, the survival was the poorest for triple valve replacement cases when tricuspid valve replacement was combined with mitral and aortic valve replacement. No late mortality in concomitant AVR and concomitant PVR group. And this was a highlight. So you have to shift the slide. I'll just go through this slide again. I think I forgot to say shift the slide. So the second outcome that, yeah, please take. Go back, please. Go back, please. Just stay here. So the second outcome that was calculated was late mortality. Late mortality happened in 11 cases out of 42 total cases. That means 26.2% cases during follow-up. Now, these 11 case deaths are exclusive of the 8 deaths that happened in the early post-op period. Survival in our study has been the poorest for triple valve replacement cases when TVR has been combined with AVR and MVR. No late mortality, luckily, was recorded for concomitant AVR and concomitant PVR groups. Now, this is the same as the outcome was for early mortality. No early mortality in concomitant AVR and PVR, and no late mortality also for concomitant AVR and PVR. Average follow-up that we took was sometimes with high INR and sometimes with wound infections, but no major morbidity or mortality with these hospital admissions. No structural valve changes or high pressure gradients detected in follow-up echocardiograms. Total mortality. Now, if we take these 19 cases, 11 in the late and 8 in the early, and divide them as per the type of valve. So 5 out of 11 cases, 11 cases were for mechanical valve, and 5 of them died. So 45.5% was the death rate among the mechanical valve cases. And 13 were biovalve. Out 31 cases were those cases in which biovalve was implanted, and 14 had died. So 45.2% cases were those cases was a death rate recorded with biovalve. So we can see that mortality rate for mechanical versus biovalve is more or less the same. Patients who presented with class 4 symptoms, sometimes high NYHA and CHF, were managed indoors with no significant morbidity or mortality. So I would like to summarize the next slide, please. I would like to summarize the outcomes that we, next slide, please, that we recorded in our study. So this is a summary in a tabular form. Please go back, sir. Go back, sir. Okay. So whatever I have spoken, the thing has been summarized. Early mortality, 8 cases. Late mortality, 11 cases. No mortality for concomitant PVR and AVR, and the highest mortality for concomitant MVR and AVR. As per the valve types, the mortality rate is same. Mechanical, the last, do we have a cursor? Sorry, go back, please. Okay. The last thing that has been mentioned in the table, mortality according to the valves, mechanical and biological. We can see that more or less it is the same, the mortality rate. Okay, so next slide, please. Okay, so now we have seen the outcomes of the study, we have calculated the outcomes. Now coming to the discussion part. It says that accepted surgery for tricuspid valve all over the world is repair. And the same goes for our institute also. We also follow this protocol that whenever tricuspid valve intervention is required, go for repair first. When severe structural alterations and dysfunction is there, replacement has to be done because repair is not amicable in such cases. There's the same thing that has been said in many of the studies done by many of the, say, for the likes of McGrath et al. They said that TV surgeries comprise of 5.7% of all valvular interventions. Okay, now to this 5.7%, only 1.7% of all TV surgeries are replacement, rest are repair also. So supporting repair as a preferred option. When other valve surgical interventions have to be done, as a composite procedure, it augments the risk with poor prognosis. Morocco et al. In their isolated TVR cohort study reported 85% survival at 1 year, 79% at 5 years. Outcomes of early mortality as reported by Call and Mercer were 36.8% for isolated primary TVR and 35.2% for isolated secondary TVR in 1990s. This study was done in 1990. Now, they said that the mortality rate for isolated TVR was 36.8%. In our study, it is coming to be 20% for isolated TVR. Obviously, in the past 30 years, we have grown, we have evolved with better cardioprotection techniques, better management of post-op complications, better ICU management, right ventricular failure, liver dysfunction. So, I mean, taking nothing from Call and Mercer, it is the thing that happens, the improvement that happens with time, progression, what we can call it. So, next slide, please. Okay, early mortality rate, as I have already spoken, that 8 cases out of 42, 19%, we had early mortality. Mostly these cases are high-risk surgical candidates with higher age group, concomitant surgeries done, longer duration of aortic cross-clamp, CPB, hepatic dysfunction, high mean pulmonary artery pressure, people who present with tricuspid valve stenosis or regurgitation in a very advanced stage. They have severe right ventricular dysfunction, high mean pulmonary artery pressure, and sometimes a second surgery has to be done, redo surgeries. So most commonly reported cause of death is in our study was right ventricular dysfunction for early mortalities. The same thing, what Kaplan et al., the likes of Kaplan et al., in 2002, they stated that overall the risk factors for death include high pulmonary artery pressure, previous cardiac surgeries, older than 55 years, perioperative edema, longer duration of cross-clamp and cardiopulmonary bypass, and advanced preoperative functional class. And RVF, that means right ventricular failure, was a standing out cause of death as said by Kaplan and et al. In the same finding we have recorded. So I'm just trying to cement our findings with what is available in the literature. Okay. Overall, 1 year survival was 23 cases have survived. That means 54.8 cases in our study have survived. Okay. Kaplan-Meier survival rate. There was a study done by Cheng et al. In which they have said that 59% was the 1 year survival rate for isolated TBR cases. Ours is coming to be 54.8%. Shade better, but more or less the same. So we are matching with the literature also. Okay, now coming to next slide, please. I think I've already spoken about this slide. Just give me a minute. Kaplan-Meier survival rate, as calculated by Cheng et al. In their work for isolated TBR cases, was 59%. Our survival rate for 1 year is 54.8%. That is a shade better. A shade better, but more or less it's matching with the literature also. Next slide, please. Next slide, please. Okay. So the choice of valve for sir, go back, sir. Please go back, sir. The choice of valve for tricuspid valve replacement is still controversial, whether to go for a mechanical valve or biological valve. Right heart has got lower pressures and lower stresses as compared to left. So the biovalve, the lastingness, the longevity of biovalve is better in the right heart. Biovalves, they do not require lifelong anticoagulation. They cause less hemorrhage and thromboembolic complications. But on the contrary, they are prone to degeneration and they require redo surgery sometimes. Mechanical valves are good for good hemodynamic properties, low gradients, low disturbances in flow, long durability, even in high stress chambers, for example, between LA and LV, but are more prone to thromboembolism and hemorrhage. Cho et al. In 2013, they have done a comparative study of mechanical valve versus bioprosthetic valve in TB in tricuspid valve position. and concluded that with regard to event-free survival, there is no statistically significant difference between mechanical and tissue valve. And the similar has been our finding, that at least the survival was the same for whether you go for mechanical or biological valve. We in our institute have preferred bioprocesses. Why? Because lifelong anticoagulation is not required. And sometimes we have patients who have got contraindications for anticoagulation. For example, pregnancy, older patients with low life expectancy. So in all these cases, we have gone for biovalves. Mechanical valves are preferred basically for young patients. And if another mechanical valve has to be implanted at the same time, if you are doing a mitral valve replacement with mechanical valve, it's better to, you can go for both tricuspid as well as mitral valve. Both mechanical valves can be implanted because as such, you will have to give anticoagulation for mitral valve. Mortality as per type of valve was comparable in both the groups. I've already spoken that around 45.5% in mechanical and 45.2% in bioprosthetic. So again, our findings, they get cemented that there is no significant difference between the bioprosthetic and mechanical valves regarding hemodynamic parameters and early and late complications. The same has been spoken by the likes of Altani and Jabbar in their works. So now coming to the conclusion of our study. The conclusion of our study is the tricuspid valve replacement is patients are basically high-risk surgical candidates because they land up, next slide please. Next slide please. Okay, so tricuspid, I think you can go back to the previous slide. There's one data that we missed. Okay. We have preferred bioprocesses in our study, and 45.5% was the death rate in mechanical as compared to 45.2% in bioprosthetic group. The same thing has been studied by researchers like the likes of Altani and Jabbar, and they have also spoken that no significant differences between bioprosthetic and mechanical valves regarding hemodynamic parameters and early and late complications. Okay, next slide, please. I think too much of data has already been spoken. So now coming to the conclusion. In simple words, tricuspid valve replacement patients are high-risk surgical candidates with high early and late mortality. So most common cause of death was right ventricular failure in our study. The choice between mechanical, okay, I have hyperlinked this thing. Most common cause of death was right ventricular failure in this study. Can you just click on the hyperlink? Yeah. Is it working? Okay. Oh. So this is a bar diagram representing the cause of early mortality in our study. Right ventricular failure dominates all the cases. It was a dominating factor. Second was multi-organ failure. Then there were arrhythmias, mediastinitis, previous cardiac surgery, redo cases, and CVA in few cases. So first conclusion is that most common cause of death in early mortality cases is right ventricular failure. Can go back, please. Go back, please. Okay. Now coming to the choice of valve. Choice between mechanical and biological valve is still controversial. And TAVR associated with other heart valve replacement increases the risk strata of the patient, which is the highlight of our study. The highlight of our study is that it's not only the isolated TAVR cases that were included in our study. TAVR combined with other valve replacement cases were a part of our study. And we have concluded that, and we have seen that when you do a composite valve replacement, it increases the risk strata of the patient. This is basically the highlight of our study because most of the tricuspid valve replacement studies have been done for the cases of isolated tricuspid valve replacement. I think TAVR has been hyperlinked. I just want to show a diagram. So can you just click on the hyperlink? Line number 4, TAVR, I have hyperlinked it. Yeah. Next slide, please. Sir, can you just, okay, just wait, yes. So in our study, I think this is a diagrammatic representation. I've tried to, so that it is more easy to grasp. Mortality, both early and late as per type of surgical procedures. Now, early mortality has been painted in blue and late mortality has. Okay, so isolated TVR, 15 cases were done, 3 were early mortality and 4 were late mortality. TVR with MVR, 16 cases were done. We had 6 mortalities, 3 early and 3 late. No mortalities, luckily, for TVR with AVR and TVR with PVR, pulmonary valve replacement. Triple valve replacement has recorded the highest mortality in our study. 2 out of 8 cases, 2 were early mortality, that is less than 30 days. And 4 cases were we recorded as late mortalities. Go back, sir. And for the conclusion slide. Please go back, sir, for the conclusion slide. Okay. So 2 conclusions are already spoken about. Right ventricular failure, commonest cause of death. And we had 19% early. That means 0 to 30 days mortality and 26.2% late mortality, making a composite of 45.2% mortality at the end of 1 year. The conglomerate of cases of isolated TVR and multiple valve replacement cases in our study highlights the higher mortality. Our mortality could be a shade higher than what has been recorded in literature, but what I want to say that in our study, we have included composite valve replacement cases. So it is expected that higher mortality rates can be encountered. Lastly, no differences in the effect of mortality as per the valve type has been observed. So this line has also been hyperlinked. Can you just please click it? Last line. Last line. Yeah. So as per the valve types, both the valve types, they have recorded approximately 45% mortality rate. So whether you implant a biological valve or you implant a mechanical valve, the mortality and the event-free survival is more or less the same. Next slide, sir. Next slide. So this is some information about the authors. Dr. Archit Patel, Associate Professor, Department of CVTS. Dr. Rahul Singh, Associate Professor, Department of CVTS at UN Mehta Institute of Cardiology and Research Center. And Dr. Neerav Parekh are basically they are with me as the authors of in the study. And myself, Dr. Shobhit Mathur, I am the corresponding author of this study and of this publication. And I am an assistant professor at Department of CVTS. So just want to say one thing, that basically tricuspid valve is like a forgotten valve. I mean, there are not many research papers, not many studies that have been conducted on tricuspid valve. So we had this data and we thought of publishing it because it was a composite data, I mean, composite valve replacement data. Next slide, sir. Next slide, sir. Regarding financial support, as this was a retrospective study, so we didn't require any financial support. There was no conflict of interest, and ethical approval was taken. But since it is a retrospective analysis only of the surgical outcomes using medical records, no intervention has been done, no new intervention was planned, no new medication was planned. So prior ethics committee approval was not taken. Regarding this publication, next slide, sir. This publication has been published in the Journal of Heart India 2023, a December edition. These are the details when it was submitted, when it was published, when it was revised. And next slide, sir. Finally, sir, a word of thanks for the organizers.